everyone, my name is Dr. Vaidehi Desai Shah. I'm a consultant robotic gynecologic surgeon and an obstetrician and an international faculty for obstetrics and gynecology. So I welcome all of you to my official YouTube channel, Dr. Vaidehi Desai Shah's Obstetrics and Gynecology. You can also join my Facebook page, Dr. Vaidehi Desai Shah's Obstetrics and Gynecology Discussion Forum. So do like, subscribe and share to my official channel. And let's begin the fourth episode of COVID Diaries in Obstetrics and Gynaecology. So let's begin the fourth episode of COVID Diaries in Obstetrics and Gynaecology. So we have a patient, Mrs. Erica, a 30 years old female who is gravida to para 1 with 31 weeks period of gestation, who presents with a history of cough, fever, breathlessness since 2 days. There is associated history of loss of taste and smell. She says that she had one episode of abdominal pain and contractions occurring every 2 hours before arrival. On examination, her pulse is 80 beats per minute, blood pressure is 128 by 74 millimeters of mercury. Temperature is 100 Fahrenheit, respiratory rate is 15 per minute, oxygen saturation is 97%. Pelvic examination shows abdominal distension appropriate for gestation, back towards left side, cephalic presentation with the head engaged, fetal heart rate is 140 per minute, 1 to 2 contractions are felt for 10 minutes. Per vaginal examination shows cervix to be 3 centimeters dilated, soft, 3.5 centimeters in length, head is at station 0, membranes are intact. The routine investigations and recent USG is normal and rapid antigen test for COVID-19 was positive. Which of the following drugs should be given to the patient? Option A is magnesium sulfate. Option B is administered glucocorticoids for fetal lung maturity. Option C is tocolytics must be given to halt the progression of her preterm labor, and D is all of the above. So let us look at this question and understand it's in the previous part we have already discussed about the categorization of COVID-19 infection in pregnancy. So if we look at this patient is already in labor, right? Because she is she is presenting at 31 weeks of period of gestation, and she is having regular abdominal uterine contractions occurring rhythmically along with changes in cervix. So there are cervical changes as well. All right. The vitals seem to be normal and oxygen saturation is 97%. So if you see such kind of patient in labor, the RCOG has clearly recommended new guidelines in which we need to triage the patients, pregnant patients with COVID-19 in labor. So what are the guidelines of triage of pregnant patients in labor? So whenever a pregnant patient is in labor, we need to categorize them into this triage forms as green, yellow, amber, red, and purple color, right? According to this triage system, green is the most benign variety, most benign category, in which the SpO2 level is 94 to 98% on room air and respiratory rate is less than or equal to 20. So this patient will not require any special oxygenation. There will be no need to admit this patient except this patient needs any obstetric or medical concern. For example, our patient is a case of preterm labor. All right. So this patient falls under the green category. There is no need to oxygenate this patient, and this patient will be admitted only for the obstetric indication, that is preterm labor. All right. If this patient had no other obstetrical indication, then this patient can be discharged at home for self-isolation. All right. Next category that comes is the yellow category, in which the target SpO2 level is 94 to 98% with FiO2 of 28% and or respiratory rate more than or equal to 21 breaths per minute. So in this patient's oxygen flow rate has to maintain SaO2, that is saturation of oxygen of 94 to 98%. That is our target. So this patient will be oxygenated. All right. So from yellow category onwards, we will be oxygenating the patients. All right. Oral prednisolone can be given for this patient, and the fetal well-being must be assessed. fetal monitoring must be done, steroids for fetal lung maturation must be given, and magnesium sulfate must be given for the fetal neuroprotection of the baby. All right, if the baby is preterm. All right, so this is very, very important. Amber category means the target SpO2 level is 94 to 98% with FiO2 of more than 35% and or respiratory rate more than or equal to 25 breaths per minute. So this patient also will have the same target of maintaining the SpO2 of 94 to 98%. Consider giving oxygen using a non-rebreathing mask, and this patient may also be given steroids and magnesium for neuroprotection, and the timing of delivery must be considered. The red category of the patient will have SpO2 levels less than 94% on 15 liters per minute oxygen via non-rebreathing mask. So these patients are the one in which urgent review must be done by the intensive care team, and emergency cesarean section must be be ready for these patients, and also 1 shot of emergency corticosteroids for lung maturation and magnesium sulfate must be given if the baby is preterm. And then the last category is the purple category, known as the peri-arrest category, in which this patient is at risk of developing cardiac arrest, and CPR, cardiopulmonary resuscitation, must be done. So adult cardiac arrest team, obstetric and neonatal crash team must be called. All right, so this is a triage system adopted by RCOG. Now, according to the latest guidelines for the management of COVID-19 by the Maternal Fetal Medicine Unit, which has been published in American Journal of Obstetrics and Gynaecology, there are certain medications which are used for management of the preterm labor in case of COVID-19 pregnant patients. Say, for example, that depends upon the gestational age and the symptoms of the female, right? If the gestational age is less than 32 weeks and if the respiratory symptoms are mild to moderate, then steroids are given for lung maturation. Indomethacin may be considered if nifedipine is not an option. This is a tocolytic agent, and magnesium sulfate must be given for neuroprotection. If gestational age is less than 32 weeks but with severe symptoms, then whether or not whether or not to give steroids is a joint decision of the pulmonary critical care unit and the neonatal unit. But anyways, 1 dose of steroid can be given. Nifedipine is used for tocolysis in case of severe respiratory symptom category with less than 32 weeks, and magnesium sulfate must also be given, right? But that will be a joint decision of the neonatal and pulmonary critical care team. If the gestational age is between 32 to 34 weeks with mild to moderate respiratory symptoms, then steroids for lung maturity can be considered. Nifedipine must be used. So if you look at the overall profile, nifedipine is the safest, is the most commonly used tocolytic used for the COVID-19 pregnant patient. Now, if in between 32 to 34 weeks, if there is severe respiratory symptoms, avoid using steroids for fetal lung maturation. Remember that between 32 to 34 weeks, if the respiratory symptoms are severe, then avoid usage of corticosteroids for fetal lung maturation and use nifedipine for tocolysis. Use nifedipine for tocolysis, right? If the gestational age is between 34 to 36 weeks, and irrespective of the respiratory symptoms, avoid using steroids. So this guideline clearly states that there is no role of usage of corticosteroids for fetal lung maturity after 34 weeks. So between 34 to 36 weeks, do not use corticosteroids, and indomethacin is not indicated after 34 weeks. All right. After 32 weeks, Usually nifedipine is given, but after 34 weeks, indomethacin is never indicated. All right. So these are the guidelines from the American Journal of Obstetrics and Gynaecology Maternal Fetal Medicine Unit with their updated guidelines in 2020. All right. So now let us understand the sites of action of tocolysis. So we have the different tocolytic agents. One is the beta-2 agonist. Second are the nitric oxide donors. Then we have the calcium channel blockers like magnesium sulfate. And then we have the oxytocin receptor antagonist, that is atosiban. And we have COX inhibitors, right? That is indomethacin. Out of all of them, atosiban is considered to be the safest safest tocolytic agent, which is an oxytocin receptor antagonist, and it is the specific tocolytic agent. All others are the non-specific ones. So what are the indications of cesarean section in this case? Cesarean section in case of a COVID-19 pregnant patient is, the indications are obstetric indications, fetal distress, septic shock, and acute organ failure. These are the only 4 indications that we have for cesarean section in case of COVID-19 pregnant patient. So if we look at the answer for this question, the answer is all of the above. Magnesium sulfate for neuroprotection, corticosteroids for lung maturity, and tocolysis to temporarily halt the progression of labor, and the tocolytic of choice is nifedipine for COVID-19 pregnant patient with preterm labor. All right. So with this, we will be finishing our discussion on COVID Diaries episode 4. Thank you for patient listening. Do like, subscribe, and share my YouTube channel. This is Dr. Vaidehi Desai signing off. Bye-bye. Have a good day.